Hello, good evening. Welcome to those who are joining. I'm Eloise, the founder and CEO of The Ribbon Box, and we are delighted to be speaking this evening with Marco Gaudoin, Medical Director at TFP Fertility. So welcome. Thank you so much for joining myself and our registrants today to talk all about treatment options for endometriosis. And we've had some great questions which have come in. Obviously, March being Endometriosis Awareness Month is timely, so we very much appreciate your expertise this evening. Please do introduce yourself.
Good evening, ladies and gentlemen. As Eloise introduced me, I'm Marco Gaudoin. I'm the Medical Director at TFP GCRM in Glasgow, but we have clinics throughout the UK. I'm an obstetrician and gynaecologist, and I set up GCRM in 2006 with Professor Richard Fleming, who is a world-renowned IVF scientist. Richard is the guy who actually developed the original long protocol back in 1982, so at the very inception of IVF. But he then wanted to move on and develop IVF further, and GCRM pioneered what has been adopted globally as individualized stimulation protocols. And that was with the aim of minimizing the risk of OHSS and maximizing pregnancy rates. And that approach has been adopted globally. I'm not going to talk about that today because we are talking about endometriosis. But that's just a background of me, really. But we are talking about endometriosis, and the definition of endometriosis is endometrial tissue. So that's the lining of the womb that occurs in sites other than in the lining of the womb, other than in the uterine cavity. And so this is what's called ectopic endometrium. It's occurring somewhere where it shouldn't occur. But that endometrium still responds to the same hormonal changes that happen throughout the menstrual cycle. And that means that when you have a menstrual bleed, that ectopic endometriosis, it bleeds as well. And bleeding, that's blood that's meant to be in a blood vessel is no longer in a blood vessel. And that causes pain and it causes scarring, and that scarring can occur anywhere. And if that scarring occurs on the fallopian tubes, that will then affect the fallopian tubes. But it's not just that. Endometriosis has a lot of effects on egg quality. It affects the actual chemicals that the endometriosis produces, affects the motility of sperm. So sperm don't swim so well in the body. And it also affects the function of the fallopian tubes, that the cilia, the wee hairs that line the fallopian tubes that help an egg get down the fallopian tube, it affects the cilia function as well. So how does endometriosis happen? So pathogenesis is just a posh word for how does something happen pathologically. And there are three theories. There's what's called the implantation theory, where the endometriosis, the endometrium from the lining of the womb flows backwards along the fallopian tube and implants in the pelvis. There's the theory of coelomic metaplasia. So the coelom is the lining of the internal organs in the abdominal cavity, and coelomic metaplasia actually explains why you can get endometriosis in other areas other than in the pelvis. You can get endometriosis in the lungs. You can get endometriosis all over the body, and in fact, men can get endometriosis as well. Now, men don't have a uterus, of course, but coelomic metaplasia explains why men can also get endometriosis. Rare, but it happens. And the third theory is that the cells from the endometrium get into the lymph vessels and into the blood vessels, and then they spread throughout the body as well. But again, lymphatic and vascular dissemination doesn't explain why men can get endometriosis. And so I'm a fan of the coelomic metaplasia theory. But how does it manifest itself? Well, you can have minimal disease and actually get very little in the way of symptoms. Conversely, you can have what's called minimal disease, minimal staging, and it really have quite profound painful symptoms. And that pain can be what's called secondary dysmenorrhea. So that's dysmen is painful periods, and it's secondary because it's secondary to the endometriosis. It's the endometriosis that causes the pain. And you can get chronic pain, you can get backache. If it's affecting the nerves in the pelvis, you can get dyspareunia, which is painful intercourse. If it's on the bowel, you can get rectal pain, and indeed you can get rectal bleeding, monthly rectal bleeding, if it infiltrates all the way through the bowel. And it can cause heavy, painful periods as well. And what we're talking about today is the impact that endometriosis has on a woman's fertility. It's graded. What the RAFS is, the Revised American Fertility Society scoring system, and it's graded from stage 1 to stage 4. So stage 1 is where it's just minimal disease. It might just be affecting the peritoneum. So POD is the pouch of Douglas, which is the space behind the womb, but in front of the rectum. So you can just get minimal disease there. But if it starts to affect the ovary, if it starts to affect the fallopian tube, if it starts to affect the bowel, then that's progressively getting a higher stage and moving along the way to stage 4 disease. And the other aspect that you can use is something called the Endometriosis Fertility Index, or EFI, which is quite an old kind of scoring system, developed in 2010, and it was aimed at trying to guide patients after they've had surgery. So it's post-surgical guidance and trying to predict their chances of natural conception after surgery. And it's not used widely because nobody's ever done any studies looking at how you could use such a score in patients who haven't had surgery. And I'll come on to surgery in a wee bit. So it's not actually commonly used, but you might read about it if you're reading about endometriosis. This is just a few pictures taken off the internet. And so here you've got the arrows pointing to a wee spot of endometriosis in the pelvis. So this would be stage 1 disease here, the classic kind of what looks like powder burns on the peritoneum. Whereas this is more extensive disease. You get these flame-like vesicles, red vesicles here, and a lot of kind of increased vascularity. And then you've got more bleeding in the pelvis here as well. And then the ovary is kind of in the bottom left-hand corner of the screen here. It's been opened up, and that's an endometrioma, which is an endometriotic cyst in the ovary. But this is affecting the fallopian tube and the ovary. So this would certainly be kind of stage 3 disease, not quite stage 4 yet, but stage 3 disease. How do we manage endometriosis? Well, that depends on your individual desires. So it is tailored to an individual's patient. Pain relief is important because if you're in constant pain, you just can't function. So you do need to, be able to function and get on with your day-to-day activities. So analgesia, and that can be from paracetamol, but not especially effective. But the commonest analgesia to help with endometriosis that isn't going to affect your fertility is things like ibuprofen, Nurofen, Ponstan, that's mefenamic acid, these kind of things. They can help, and they're not going to affect your fertility. Hormonal suppression is probably the most effective way of controlling pain associated with endometriosis. Unfortunately, it is contraceptive, so that's no good when it comes to a couple who are trying to conceive. So non-steroidal anti-inflammatories for the pain, hormonal manipulation if you're not trying to conceive, but that's no good if you are trying to conceive. Analgesia, said, non-steroidals, it treats the symptoms, but it doesn't treat the cause. But treating the cause of the endometriosis is a very difficult area. Okay, but as I said, it has no impact on your fertility or infertility, one way or the other. Surgery, you can burn away the endometriosis if it's kind of superficial disease using either diathermy or a laser, and it can be helpful, but you can't really treat kind of major or deep-seated disease with surgery. It really has to be chopped out. Or with laser, you can't treat it with laser. You can remove an endometriotic cyst, which is called a cystectomy. The risks with that are that inevitably, by trying to remove the endometrioma, the endometriotic cyst, you will remove good ovarian tissue as well. And this is the dilemma, because what you want to do is to maximize a woman's fertility, but also by not removing a lot of ovarian tissue, but you also want to help her symptoms. But to do that, you have to remove some good ovarian tissue as well. So there is this, you're caught between the devil and the deep blue sea when it comes to doing a cystectomy. If it's really bad, you have to remove the whole ovaries. That's called oophorectomy. And if it's really, really bad, pelvic clearance, removing the ovaries, removing the womb, as much endometriosis as you can is the final solution, if you like. When it comes to infertility treatment, there's medical suppression of the endometriosis, there's surgical treatment, ovulation induction, and then IVF and ICSI if the sperm count is low, and we'll cover each of these. So first of all, medical suppression. You can use the pill, you can use progestogens like Dufaston, you can use GnRH agonists, so like Prostat. All of these are very effective at suppressing endometriosis. The analogs, GnRH analogs, are the most effective, but they also have the most side effects in the way of menopausal symptoms. And the problem with all of these is that they are contraceptive. So you can't use them if you're actually trying to get pregnant. They're great for treating the pain, but not good if you're trying to get pregnant. And the difficulty also is that whilst these medical treatments might suppress the endometriosis, they don't improve subsequent pregnancy rates. So they're good if you're not trying to get pregnant, but not of any great value if you actually are trying to get pregnant. So people have tried to say, well, let's put you on the pill for 6 months and then try naturally. That hasn't been shown to be beneficial, because all you've done is delay trying to get pregnant for 6 months. And you probably all know that the longer you, or the older you are when you're trying to get pregnant, the less successful you're going to be. So these delays, these built-in delays by using these medical treatments, unfortunately, don't help subsequent pregnancy rates. So as I say, it just delays fertility. So if you're trying to get pregnant, then ESHRE, which is the European Society for Human Reproduction and Endocrinology, ESHRE say, you shouldn't use them for the subfertile patient. Great if you're trying to control pain. Great if you're not trying to get pregnant, but just want to kind of just suppress things, but not if you're trying to get pregnant in the here and now. And they can be used post-surgery if you're not wanting to get pregnant in the here and now. Surgical treatment, if it's stage 1 or 2 disease, so early disease, if you like, you can use diathermy laser to destroy the superficial endometriosis. And then if the fallopian tubes aren't affected, you could continue to try naturally, assuming that the male partner has a normal sperm count. So it may have its place in selected cases. If you have an endometrioma, so that endometriotic cyst, then you can simply drain the cyst laparoscopically. The problem with that is that drainage, you're not really treating the endometriosis, you're just emptying that big cyst of the chocolate, what's called a chocolate cyst. When you open up the cyst, it just drains, it looks like hot melted chocolate. And you can suck it all out, but the problem is that the endometriosis and the endometrioma just tends to recur. So you can try and strip the endometrioma away from the ovarian capsule, but inevitably, as I mentioned earlier, you do remove good ovarian tissue as well. And the more ovarian tissue you remove, the greater the impact that's going to have on subsequent fertility in a negative way. What is a newer kind of approach is what's called sclerotherapy, where you actually use alcohol to destroy the endometriosis. You put the alcohol into the endometrioma with a balloon catheter, and you just let the alcohol destroy the endometriosis. And sclerotherapy has been used in surgery for many years for things like varicose veins, and using alcohol to kind of burn away or just to close off the varicose veins. And endometriosis is a very vascular thing. So what you're doing is just trying to destroy those vessels. And I think that it's not widely used, and there's not a huge amount of data on it. But I think this has a place as it becomes more widely used. That it'll help, because it's not destroying as much ovarian tissue as excision might destroy. But the problem with all of these things is there's no data on subsequent natural conceptions. So if you've got a big endometrioma, and you're treating it in some way, you're then thereafter still looking at IVF treatment. But these treatments can be done in the NHS, your local NHS hospital, or they can be done in the private sector. I don't know where people are joining from, but I work in Scotland, in Glasgow, and our waiting lists in the NHS are just huge. And COVID has a lot to answer for. One of the things is that waiting lists in the NHS are just huge. In Glasgow here, it's actually almost 2 years just to get an outpatient appointment, let alone surgery. So it's pretty grim, unfortunately. And so more and more of my patients certainly are turning to the private sector because they just can't afford to wait. My personal views on endometriosis, on endometriomas, as I said, drainage tends to recur, so I don't advocate that. Excision, but try to avoid, if you can, and if you have to excise, try and be as conservative about the amount of tissue you're removing, because what happens is you end up removing good ovarian tissue, which means that you reduce the AMH production, anti-Mullerian hormone production from the ovary, which then has a negative impact on the chances of IVF working. And as I said, I think sclerotherapy, not widely used in the UK, but I think that does, have a place, and I think should be used more widely. And certainly all these things can provide symptomatic relief, but as I mentioned earlier, do they actually help in subsequent natural conception? And the answer is we don't really know. So what I tend to recommend to patients is, if you're getting a lot of pain from your endometrioma, then certainly operate in some way, or have a gynecologist operate, but be conscious of it, be aware of the downsides, particularly with the reduction in AMH production, which then has an impact on the chances of IVF working. When it comes to fertility treatment itself, if it's early disease, stage 1, stage 2 disease, and the fallopian tubes are patent, if they're open, then intrauterine insemination may be beneficial, especially if you're a single woman using donor sperm or a same-sex couple using donor sperm. If it's a heterosexual couple, then even if fallopian tubes are patent, then intrauterine insemination probably doesn't have a place, because studies show that in couples where the fallopian tubes are patent, IUI, intrauterine insemination, is no better than trying naturally. As I said, it's useful if you're using donor sperm. If it's stage 3 or stage 4 disease, then you're immediately looking at IVF treatment and ICSI treatment if there's a low sperm count in the male partner. When it comes to IVF ICSI, I don't know if many people who are joining have had any IVF or ICSI treatment, but there's millions of consent forms to sign. We're very highly regulated by the Human Fertilization and Embryology Authority. So there's millions of HFA consent forms to sign. There's loads of screening tests you have to have: HIV, Hep B, Hep C, rubella. There's all sorts of things that need to be done. IVF itself is daily injections on average for about 10 days. The stimulation protocol, certainly in Glasgow at GCM, where we've pioneered individualized stimulation protocols, is dependent on the woman's AMH level. Egg retrieval is done, for those of you who've had an internal scan, it's exactly like that. But you're asleep, because the needle goes to the top of the vagina, into the stimulated ovaries, into the follicles. Then we suck out the fluid from the follicles to get the egg. So that's egg retrieval. And then we get the eggs, we mix them with the sperm for IVF, or with ICSI, you're injecting a sperm into the egg. And a fertilized egg is called an embryo. But that embryo goes through various stages of development over the course of the next 5 days. So by day 5, it should have developed into what's called a blastocyst, which is just a posh word for a day 5 embryo. And an embryo has to make it to the day 5 stage in order to implant. So now, pretty much universally, we culture embryos to the blastocyst stage and then have an embryo transfer at that day 5 blastocyst stage. And the embryo transfer is like having a smear test. From the woman's point of view, it's like having a smear test. From our point of view, it's obviously a bit more involved than that. What we're doing is putting a fine catheter through the cervix into the womb and ejecting the embryo directly into the lining of the womb. So that's an embryo transfer. If we look at treatment outcomes with endometriosis, sadly, we know that egg yields are lower. That's probably because women with endometriosis, having had destruction of the ovaries, their AMHs are lower. We know that implantation rates are reduced. So endometriosis, if you look at women who have endometriosis, their implantation rates are lower than in women who don't have endometriosis when you match them for age and all other kind of factors. But sadly, even in women using donor eggs, implantation rates are lower. So endometriosis does have an impact. Well, sorry, beg pardon, but not with donor eggs though, because that's okay. But overall, we know that live birth rates are lower, and that the live birth rates decline with increasing severity of the endometriosis because of the impact the endometriosis has. One of the common questions that people ask is, will the infertility treatment itself make my endometriosis worse? And the answer to that is probably not. The stimulation from IVF itself is a very short-lived thing. And so, yes, you do have higher estrogen levels during the course of stimulation, but it's really only for about kind of 10 days or so. If you get pregnant, in fact, the high levels of estrogen during pregnancy are actually higher, but also in pregnancy, you've got very high levels of progesterone, which then suppress the endometriosis. So the good news is that infertility treatment doesn't worsen your endometriosis. And if you get pregnant, you suppress the endometriosis. So if you get pregnant, it's a really good thing from an endometriosis point of view. What we do is we do give antibiotics during the egg retrieval, particularly if you've had to puncture the endometrioma, because that chocolate I mentioned earlier is a great kind of breeding ground for infection. So we do give prophylactic antibiotics if we puncture the endometrioma. So in summary, endometriosis is just ectopic endometrium. The lining of the womb is occurring somewhere else in the body, most commonly in the pelvis, on the ovaries, on the peritoneum, and on the fallopian tubes, but it can occur anywhere in the body. What causes it, the pathogenesis, is open to debate. My personal views are that it's coelomic metaplasia is the cause. It's graded from stage 1, which is minimal disease, to stage 4, which is severe disease. When it comes to infertility treatment, there's unfortunately no place for medical suppression of the endometriosis, because all it does is delay treatment, and age is the biggest enemy of fertility. Surgery is contentious. If you have pain, as I mentioned, then I think surgery has a place, but otherwise, waiting for surgery, all you're doing is getting older, and that is the biggest killer. Intrauterine insemination, IUI, may have a place with stage 1 or stage 2 disease, but only really in women who are using donor sperm. And with stage 3 and stage 4, even if you're using donor sperm, it's IVF treatment. And unfortunately, women with endometriosis do have less good outcomes than women who don't have endometriosis. So endometriosis is unfortunately not good news for fertility. Having said that, there's millions of women with endometriosis who've had millions of babies. So if you have endometriosis, you shouldn't despair, because it can still happen for you.
Thank you very much, Marco. That was very, very thorough and useful, especially to see imagery as well. Marie has asked live, how far away are we from the more modern treatment becoming routine in the UK? And is there anywhere in Europe offering this?
So if you're talking about the sclerotherapy, the answer is I don't know. It's not used in Glasgow, certainly, as far as I know. It was originated in Germany, and so it's kind of spreading across Europe. Some places in London. What you should really do is seek out, if you have endometriosis and severe endometriosis, seek out a gynaecologist who has a proven track record in endometriosis surgery. Mm-hmm. So we do have an endometriosis service in Glasgow. The problem is the waiting times are just massive.
Mm-hmm. Unless you go privately.
Yeah. But even there, it's because there's so many people going privately, it's still pretty long, unfortunately.
Okay. Why does it take so long to diagnose endometriosis for so many people? You hear of stories of sort of 8-10 years plus.
So the reason for that is that traditionally we've always thought that endometriosis was a disease of the older woman. There are certain predisposing factors for endometriosis, one of which is increasing age. The longer you've lived, the more likely you are to get it. There are other things like the less pregnancies you've had, the more likely you are to get it. There's a genetic predisposition to endometriosis. So if your mum had endometriosis, you're more likely to get it. If your sister has endometriosis, you're more likely to have it as well. The problem is getting people to recognize these risk factors, but also to then say, well, lots of women have primary dysmen, so primary painful periods, which is just what young women get. And so, and it's just kind of dismissed as being primary dysmen. It's not endometriosis, which is secondary dysmen. So it's really dismissed. Or you say, well, yeah, you've got primary dysmen, or you've got dysmenorrhea, and we can just treat it with non-steroidals, we can treat it with a pill, but we're not actually going to investigate it. Because ultimately, unless you can see an endometrioma on an ultrasound scan, the only way to diagnose endometriosis is to do a laparoscopy, which is a surgical procedure, which needs then a general anaesthetic and all the waiting time and everything else in the NHS to get that done. So there's a lot of built-in delays, not just from waiting to be seen in the NHS, but just saying, well, this could just be primary just men, and we'll just treat you, kind of thing.
Leading on from that, can you please advise what women should tell GPs to access services more quickly, as women often feel dismissed and normally start there before going to a fertility clinic, for example?
So the answer to that is, I'm really concerned that I might have endometriosis, and I know that endometriosis has an impact on my fertility. So please, could you refer me accordingly? Because I've got all the symptoms of endometriosis. So I've got symptoms of potential endometriosis. It has an impact on my fertility, quite definitely. So the sooner that's addressed, the better, and the sooner my potential decline in fertility is addressed, the better. Because, as I keep mentioning, age is the biggest factor in declining fertility.
So, what is the relationship between AMH and endometriosis?
So women with endometriosis tend to have a lower AMH because the endometriosis itself, if it's on the ovary, if it's on the capsule at the outside of the ovary, it's still destroying bits as it bleeds each month and causing scarring. That's then destroying more ovarian tissue, which means that your follicles are in the capsule of the ovary, what's called the cortex. And if it's destroying bits of the cortex, you're destroying those follicles, and it's the follicles that produce AMH. If you've got an endometrioma, that's even more destructive, and so it's going to just continue to destroy ovarian cortex, which means your AMH is going to go down, basically.
Right.
And then on top of that, if you then go and have surgery, and this is why I said that you want to try and be as conservative as you can with surgery, you start chopping out good ovarian tissue, you're going to reduce your AMH level.
Would you only be able to understand someone's severity of endometriosis through a laparoscopy?
By and large, yes. If you see a big endometrioma, okay, you can say that's likely to be stage 3 disease, stage 2, maybe stage 3 disease, but you can't see the fallopian tubes and where there's scarring in the fallopian tubes. You can't really see the pouch of Douglas. If the womb is pulled backwards, what we call a retroverted uterus, again, that suggests there's endometriosis in the pouch of Douglas, pointing more to kind of more severe disease. But the gold standard and the only way to definitely make a hard and fast diagnosis and how to stage it is by laparoscopy.
Okay. So would that be required prior to fertility treatment?
No, because if you can see an endometrioma, you can say, okay, you've got endometriosis. It's at least stage 2, possibly stage 3 disease. You're looking at IVF treatment regardless. So you don't need a laparoscopy. The laparoscopy will be there to make a staging diagnosis, and also if you're getting pain, to address an endometrioma or to maybe burn away endometriosis. But the surgery itself is not going to improve the fertility per se.
Yeah, makes sense. Thank you. When people are having a cycle of IVF, would you predict that there may be fewer eggs retrieved and fewer embryos developing?
The answer to that is yes, unfortunately. We know that women with endometriosis tend to have lower AMH levels for the reasons I've said, so you get fewer eggs. But it's not just that. There's the impact of endometriosis. The chemicals that the endometriosis produces then has a detrimental effect on egg quality, which means that then embryo development is compromised. So you do tend to get fewer embryos, which in turn then means that overall you get fewer embryos, so you get fewer babies, basically.
Does it affect implantation rates as well?
As I mentioned, the endometriosis per se doesn't if you're using donor eggs. So we know that women with donor eggs using donor eggs who have endometriosis have the same implantation rates as women using donor eggs who don't have endometriosis. Okay. So it's great data from Spain. Some of you may know that Spain has a huge egg donation program. So they have fantastic data sets on conditions like this, because their data sets are so big that it's really quite robust data. So endometriosis itself doesn't have an impact on implantation. It's the impact it has on sperm function, natural conception, the impact it has on egg quality, whether natural conception or with IVF.
And after surgery, anything we should know in terms of risks or anything to be aware of, recovery, timeframe, conception after surgery, assisted conception after surgery?
Yeah. So it depends on the extent of the surgery, but really what you want to do is to have fertility treatment as soon as possible after the surgery, because sadly, endometriosis just marches on. And the longer you leave it, the more likely it is to recur. So it depends on how much surgery you've had and the recovery thereafter from that surgery. But the sooner you can have fertility treatment after the surgery, the better.
Makes complete sense. I presume this does affect chances of conception, like you just mentioned, because if you leave it, it's going to come back. Could it potentially come back worse than it started before?
It won't come back worse. It'll just come back as it marches on. As I said, just simply draining an endometrioma, that endometrioma is going to come back again. You want to either ablate it using sclerotherapy or strip it out if you can. But certainly stripping it out means you remove good ovarian tissue as well.
Could it ever resolve itself, endometriosis, and just stop? Or would something like pregnancy slow it down or stop it for the 9-10 months you're pregnant?
Certainly, as I mentioned, pregnancy does suppress endometriosis because you've got high progesterone levels through the course of pregnancy. So it does suppress the endometriosis. The only thing ultimately that stops endometriosis is the menopause, because then you don't have that monthly hormonal stimulation from the estrogen that is causing the endometriosis to proliferate.
And that's why people, I presume, get put on the pill, on a progesterone pill, to decrease the effects of endometriosis.
Absolutely, yeah. And that's why people get put on GnRH agonists, because that makes you menopausal essentially, albeit temporarily for the time you're on the agonist. But you get all the flushes and sweats and things associated with the menopause. But agonists, from a pain point of view, are the most effective treatment. The problem is they make you can't get pregnant because you stop ovulating and things.
Would you suggest that people who may think they have endometriosis or have had it diagnosed look at egg freezing if they're not ready to have a child at that moment?
I would recommend all young women who aren't wanting to have a child freeze their eggs. I see the average age of patients in my clinic is over 38. And I have so many patients who say, I wish I'd frozen my eggs when I was younger because now my eggs aren't so good. The problem is that egg freezing is very, well, that's a great technology. The egg freezing it's expensive, So when you're young, when your eggs are at their best quality, you don't have the money to freeze your eggs. And egg freezing will never be offered on the NHS because it's considered a kind of a lifestyle choice. But yeah, the egg freezing, I don't know about now, but certainly how egg freezing used to freeze eggs using what's called slow freezing. The problem with that is the human egg is actually the largest cell in the body. You can see it to the naked eye. It's about 100 micrometers in diameter. And with slow freezing, it's a single cell, and cells are full of water. With slow freezing, you're not removing any of the water, so that water, as it freezes, just swells and it damages the egg. You can now, with what's called vitrification, which is a different way of freezing, where you actually suck out the water from the egg effectively. You can then freeze eggs, and there's very little water in the egg, so when they freeze, you don't damage the organelles within the eggs. So then when you come to thaw the eggs, you reverse that process, and that egg is much more viable. So on average, it takes about 17 eggs to make a baby naturally.
17?
17, 17. With vitrification, vitrified eggs, it takes about 18 eggs. So it's virtually the same.
Right.
But you want to freeze your eggs when you're young, and if necessary, use them when you're older. But vitrification has changed the game with egg freezing. The problem is, the whole process is an expensive process, and the ideal time to do it is when you're in your mid to late 20s. But women in their mid to late 20s don't have the money to freeze their eggs.
And as you just mentioned, you might need to do a couple of cycles to get that quantity of egg.
Yeah, absolutely. Yes.
Thank you, Marco. This has been so helpful. Anything that you want people to know or consider now for Endometriosis Awareness Month, but just generally day to day with family planning and fertility treatment and sort of reducing symptoms? Just any sort of parting thoughts in terms of people going out and seeking help and making that first step, and why that's
always. I keep coming back to it. Age is the biggest factor in fertility treatment. So sooner rather than later is always the mantra.
Brilliant. All right. Well, thank you, Marco, so much for this amazing advice you've given us this evening. And thank you, everyone, for joining. And we look forward to speaking to you again soon.
Thank you very much for everyone logging in.
All right. Thanks a lot. Bye-bye.
Cheers now.
Bye-bye.